Brian Harman, President and CEO of the United Mitochondrial Disease Foundation. Thank you for joining us today for our briefing, Leveraging Telehealth for Complex Patients. We appreciate you joining us as we discuss this important topic to our patient and clinical community. But first, please allow me to share a little more about mitochondrial disease and our organization and the community we serve. We all have mitochondria. They exist in nearly every cell of the human body. It's responsible for creating 90% of the energy you need to sustain life and support organ function. When mitochondria cannot convert food and oxygen into life-sustaining energy, cell injury and even cell death follow. When this process is repeated throughout the body, organ systems begin to fail and even stop functioning. Mitochondrial disease affects both children and adults, and those patients can often face a long diagnostic journey. The exact number of individuals suffering from mitochondrial disease is hard to determine because so many who suffer from the disease are frequently misdiagnosed. It is estimated 1 in 5,000 individuals has a genetic mitochondrial disease. For over 25 years, the United Mitochondrial Disease Foundation has been alongside these patients in charting a course toward treatments and cures. Our mission at the UMDF is to promote research and education for the diagnosis, treatment, and cure of mitochondrial disorders, and to provide support to affected families. To that end, we find and fund the best science, no matter where it is found in the world. We've funded over 125 research labs to date. We host educational events like our Ask the MitoDoc web series and Mitochondrial Medicine Symposium. We provide critical support programs like our Ambassador Connections, grief support, and patient concierge services. And we bring the patient voice to policymakers on Capitol Hill to ensure resources, rights, and health insurance coverage are available to the mitochondrial disease community. And that brings us to today's topic on telehealth. We are keen on reducing barriers to access and maximizing telehealth services for the benefit of our patients. And I'm delighted to introduce to you today our featured clinician speaker, who's going to share a little bit more about why this is so important to our community and to highlight some of the challenges our physicians face. Our speaker today is the director of the mitochondrial medicine at the Cleveland Clinic and the co-director of the Mitochondrial Care Network. Please join me in welcoming Dr. Sumit Parikh. Dr. Parikh?
Hi, good afternoon, everybody. I'd like to thank the UMDF for inviting me to share some of this information with all of you. Let me share my screen. And I hope all of you can see these slides. I promise we won't go on too long. Before I actually get to what we're calling this telehealth network, just to give you a little bit of background, mitochondrial disease, as Brian just said, is quite a rare disease overall, but mitochondria really do impact pretty much everything we do in our body, and they are impacted by pretty much every human disease. So we know that even though we've got this rare, small group of rare patients with rare disease, we really want to understand mitochondria and mitochondrial diseases better, because understanding them will very much help some of the havoc wreaked by other human diseases on the body. And one of the key issues being human aging and being able to slow that down. One of the things that has happened in the rare disease world is that we have formed networks of expert centers. Cystic fibrosis is a well-known example, but this has happened for cancer as well as other diseases. And just as of about 2017, 2018, we formed one for improving the care we provide for our patients with mitochondrial disease. And this was called the Mitochondrial Care Network. And Amel Kara, who's at Mass General, and myself helped co-direct it. Our goals are really to unify all the expert doctors out there who take care of these patients in the hopes that we can optimize care, coordinate care better, identify gaps in the care that we're providing, and then overall improve the quality of care so that it reduces the burden that our families face when they are caring for themselves or their children who have this disease. This is a joint effort, and it very much critically includes the United Mitochondrial Disease Foundation, another patient advocacy group, Mito Action, as well as the group of clinician doctors who take care of these patients that are part of something known as the Mitochondrial Medicine Society. And as part of this network, one of the things we've been looking at is telehealth, and this effort actually started before the pandemic, but the pandemic really kickstarted things and drove it into high gear. And, you know, one of the challenges we've always had is that we've not always been able to make the progress we want because we're always trying to aim for perfection. And, you know, when our patients and families don't have enough expert care, don't have enough access to care, we really want to start providing good enough care until we can get better. And so that has always been our goal for this network and as we move forward. So Brian did tell you that mitochondrial diseases, they are genetic diseases. They impact all ages and all systems of the body, but the brain is often involved, which is why we as neurologists often get involved in most of these patients and in caring for these patients. Because it's a genetic disorder, geneticists also play a very big role in helping with diagnostics and managing these patients. But just keep in mind that this is not just a pediatric disease. This is a disease that impacts everybody from birth to grave. And the challenge is, because it's considered a rare disease, that there is limited expertise. And that has led to a key problem with accessing care and accessing expert care or quality care. And so this is one of the things we're trying to fix. There are not enough mitochondrial docs or mitochondrial centers. We only have 24 sites that seem to meet the criteria we laid down to qualify as an expert center, where you had experience in seeing these patients and being able to provide quality care for these patients. That's multidisciplinary because it does affect every organ head to toe. And we are only covering 12 states in the United States, which is a shame. And 25 states are more than a 4-hour drive to a Mito Network site. So if you've got an ill family member who needs a consultation for their child, their sibling, their brother, or parent, they've got to get in the car and drive. And until the pandemic, to have that initial visit to establish care, our families drove. And, you know, I'm in Ohio. My catchment area has included Illinois, Indiana, West Virginia, the rest of Ohio, and parts of Pennsylvania. And then, of course, people who want to come farther out than that. But all of those other states, they've got to get, Michigan. And it's a shame that's what we have to do in this country to get expert care when we might be able to provide it another way. State licensure has definitely been a barrier. And right now we are not covering the number of states we want because state licensure is such a difficult thing to acquire and keep maintained for multiple providers. And the cost of this is quite burdensome. And so right now we only cover less than half the states in the country. So the third key portion of this is that this is a neurologic disease, and it is a neurologic disease that impairs mobility. So you might say, well, you know, it's not the worst thing to get in a car and drive 4 hours, but when we're talking about a wheelchair van, or we're talking about somebody who's having seizures several times a day, now this 4-hour journey or longer takes on a whole new meaning. So for all these reasons, we know that face-to-face office visits, while they are very nice, they have a value of care that is not the same as when we provide care via telehealth. There is also significant value to the kind of telehealth-based care that we could provide for these families with complex medical needs. And so all of you clearly by now, especially with the pandemic, know what telehealth is. And the gist of it is that it allows for Zoom or video-based technology to allow for indirect face-to-face visits that are happening synchronously with the provider as well as the family. Even before the pandemic, 80% of our sites, because we were already looking into this, were supportive of a telehealth network, and many of them were ready to go. Many of us were already doing telehealth as consultation visits and definitely for our follow-ups. But the amount and number of supports for telehealth that grew with the pandemic were exponential, and familiarity also grew, and then utilization from the patient community side also grew. And so now we have telehealth capabilities at every site. Almost all of our families and patients have used telehealth. And sure, we would still like to see our patients, lay hands on them and examine them maybe once a year or once every 2 years, but they don't have to get in their car or on a plane and come and see us twice a year and take on the burden of that trip and the cost of the trip and everything else. So our biggest fear is telehealth would allow us to fill this geographic gap immediately. If we could deal with the burden of state licensure somehow, it allows us to provide optimal care safely, considering most of the care we provide is second opinion based, or we call it backseat driving. All of our patients have primary teams that are helping them locally, and we are just helping guide and optimize care. However, we all worry that the state and federal barriers that were there prior to the pandemic, if these all go back in place, it is going to serve as a huge hindrance in being able to get our patients the quality of care we need. And so we are very hopeful that as all of you move things forward, that some of these state and federal barriers will be modified, and hopefully these will not be hurdles for us. A couple of these things would include state licensure restrictions. And, you know, we understand that maybe for common diseases, diabetes, heart disease, there may be a need for restrictions, but we would hope that there might be something earmarked that talks about rare diseases and less common diseases that require special expertise and knowledge and training, where exceptions could be made. And then, of course, from the insurances and Medicare, Medicaid providers, that reimbursement is maintained so that we are allowed to do this by our institutions and are not providing care that would jeopardize any support that this would bring to our institutions to allow for this kind of care to continue. There is already in place something called a second opinion consultation exception that allows a consultation with a limited scope for a brand new patient. Cleveland Clinic has already started trying to use that as some of the shift happens from being in the depth of the pandemic, knee deep in it, to a slightly healthier place for the country. We hope that this type of a second opinion consultation exception would still allow us to see out-of-state patients with a limited scope, providing guidance to their local teams and families as far as testing that needs to be done and treatment options that need to be provided, without us taking on primary care of these patients, and still allow for safe and optimized care for our patients. So we're very hopeful that we can maybe form something moving forward in 2021, 2022 of a hybrid telehealth network for rare disease that would allow for in-state providers to use our own institution's telehealth vendor and being able to bill patient insurance, out-of-state providers being able to use a second opinion consult mechanism, and then anybody, if needed, being able to use a grant or a fund of money, which we would hopefully help be able to provide if these other two options are not available. And I believe that is all I wanted to share with all of you today. So I very much appreciate your attention, and I will hand it back to Cliff.
Thanks so much, Dr. Parikh, for your presentation and highlighting some of the challenges our patient families face, and for your tireless effort to care for these patients and their families as well, too. You know, our patients are counting on us to reduce barriers to care, and one such patient family is today's feature family speaker, Stacy Taylor. Stacy and her husband, David, live in Towson, Maryland with their 4 sons. 2 of their boys, Sam and Marshall, are impacted by mitochondrial disease caused by a rare gene mutation, RMND1. Previously employed at the state of Maryland's Parent Training and Information Center, Stacy currently works for the Maryland Department of Health, overseeing programs related to children with special healthcare needs. Stacy has volunteered with us at the UMDF as a support ambassador since 2018, and she truly is one of our rock star mito moms. So Stacy, I'm going to turn it over to you to share a little bit about your story and your journey.
Thank you so much, Brian, and thank you all for having me here today. I'm going to share my screen, hopefully. And let's see if that worked. Can you see the slides? Okay. So as I said, hopefully you guys can see the slides. I didn't get a response that you couldn't. So thank you all for having me here today. A little word about who we are. As Brian said, my name is Stacy. That's me, second from the left, and very quickly becoming the shortest one in the group. Fortunately, I might have Sam beat as long as he stays in the wheelchair. I'm allowed to make jokes like that because he's my kid. My husband, David, and I have 4 kids, 2 of whom have genetically confirmed mitochondrial disease inherited through their nuclear DNA. And that basically means that Dave and I are both carriers of the mutated gene. So what is their diagnosis? Dr. Parikh told you a little bit about mitochondrial disease, and I think all of you probably have some background knowledge. Mitochondrial disease is not a single disorder, but is an umbrella term for dozens of more specific disorders. So specific to Marshall and Sam, the individual disorder that they have is called combined oxidative phosphorylation deficiency type 11. Say that 10 times fast. Typically, this is referred to by the gene that is mutated, which is RMND1. About 40 to 45 kids, that's not a misprint or a misspeak, it's 40 to 45, 2 digits, have been diagnosed with RMND1 worldwide. The US number is a little bit trickier. I talked to our genetic counselor, and typically that number is pulled from literature by looking at where the authors are from. But we can say with some certainty that it's less than 40. The Orphan Drug Act of 1983 defined a rare disease as a condition that affects fewer than 200,000 people in the US. So I would say RMND1 qualifies as rare. And taking a step back for a second, I think the experience of seeking out the right specialist for your particular concern is universal. I'm sure each of you have had some experience where you've had a medical issue, you've sought specialty care, and you want the best, you want the most experience, you want the provider with the most knowledge about your particular diagnosis. If you have a broken arm, you don't go to someone with expertise in diabetes. Likewise, if you have RMND1, you want to go to somebody with expertise in RMND1. And because mito does impact so many body systems, as Dr. Parikh mentioned, there are parallels with various other diagnoses. Many patients with mito are referred to providers with expertise in cerebral palsy or autism, or a provider with expertise in a specific system that's impacted. We've seen specialists ourselves at Sinai Hospital, Mount Washington Pediatric Hospital, Johns Hopkins, and Kennedy Krieger in Baltimore. We've also seen experts at Children's National Medical Center in DC, Nemours AI DuPont in Delaware, as well as private providers and smaller clinics for specific needs. And we are very fortunate to have these amazing medical facilities in our figurative backyard. I'm in Baltimore. But most of these specialists are unfamiliar with mitochondrial disease. In fact, we're educating them about the impact of mito on our children and on our family. All were unfamiliar with RMND1. Through involvement with UMDF, I was able to connect with a provider in a different state. Of the fewer than 40 children who were diagnosed with RMND1 in the United States, she's seen about 7 or 8 at this point, putting her at having treated about 20% of the US patients with this particular diagnosis. That's a rough estimate, of course. So to the extent that any provider has expertise in RMND1, she's it. And obviously, I want my kids seeing this provider, and telemedicine can make that easier and safer for them and for us. And I just want to share another brief story with you. The other day, on Tuesday, I got a Facebook message from someone that I didn't know. It was a mom in the Midwest, and she was reaching out to me because she had found my name through the UMDF Facebook page. Her son was born about a month ago. A few days ago, he was diagnosed with RMND1, and she has no idea where to turn. Her doctor has told her that he has no idea how to treat her son. He's about a month old. He hasn't been home from the hospital yet. For her, and I encouraged her to let her doctor know to reach out to the provider that I know of. But for her baby, telemedicine could be a game changer for her. And not to sound dramatic, but it could literally be a lifesaver for her baby. So that's just one example that came up very recently, and there are more. So you've probably have this knowledge about Mito already, and we talked a little bit about it. This is Marshall and Sam. RMND1 affects them in similar but different ways. Sam, the one who's laying down, is more significantly impacted. And I won't go down the entire laundry list of areas that are impacted and the variables between the two boys. But as with all mitochondrial disease, the fear of deterioration is ever present. Concerns that might be pretty trivial in other kids can be catastrophic for them. For example, a simple cold has landed both in the ER on more than one occasion. Metabolic decompensation or metabolic stroke is a danger with mito patients when they're under physiological stressors, such as illness, dehydration, even mild dehydration, fever, or temperature extremes. In fact, we do think that Sam had a decompensation episode before he was diagnosed with mito. He completely lost what little language he had up to that point, regressed in his physical abilities, and he's never really gotten back to where he was before that episode. Each time we leave the house, there are potential physiological stressors that we encounter, and we have to do a kind of a risk-benefit analysis. What are the stressors that we might encounter? What's the potential outcome if we do encounter these stressors? I know it seems morbid, but sometimes I'm asking myself, what's the worst case scenario? And can I live with it if it happens? What's the benefit of where we're going? And is it worth it? In the case of COVID, the answer was clear. The stressor was Marshall or Sam getting sick with COVID. The potential outcome was someone in the house dying, and the benefit was non-existent. And through telehealth, we were still able to see many of our providers during this period of time. I get that this risk, this enormous risk, is not the case for everyone, and that some people might think that that fear is overstated. So to put it another way, in 2019, we drove a little over 5,000 miles for medical appointments. We spent over $1,000 in tolls, parking, gas, and food while on the road. Marshall and Sam missed dozens of school days, and our other kids were left home alone on those days. I missed about 35 full or partial days of work. And this was only for Marshall and Sam, not for either of our other two kids or for any medical care for me personally. Comparatively, in 2020, while telemedicine was authorized and I was teleworking, I missed 0 full days of work. We drove a total of about 200 miles for in-person appointments. I have no idea how much we spent on gas specific to medical appointments, but I know it wasn't as much as the previous year. This is us during a telemedicine visit. They're relaxed, they're smiling, they're comfortable, and they are safe. This is us preparing for an in-person visit. We have to pack mobility equipment, including a wheelchair for Sam, a walker for Marshall, diapers, and don't even get me started on changing diapers for a 12-year-old while on the road. It's next to impossible. We pack a change of clothes because of the aforementioned challenges to diaper changes. We pack snacks and drinks, excuse me, and medical records from previous visits because I may not have access to all of my medical records through my phone. Not all providers or medical systems share records electronically or collaboratively with each other. To get to our current mito provider, we have about a 2-hour drive each way, plus the time for the visit, including wait time, vitals checks, actual FaceTime with a variety of providers. When it's all said and done, we're usually gone from our house for about 8 to 10 hours. And this is exhausting, not just for them, but for us, and puts them at risk of various different complications. And again, we're among the lucky ones. Where we live, we actually are within driving distance of phenomenal medical facilities. I haven't been to Ohio yet, but maybe someday. So some of the pros of telemedicine all the time. Patients are more relaxed. You don't have that white coat syndrome. You know, you're not having like the increased heart rate because the patient is in an unfamiliar setting. You get the perspective of more than one caregiver. For a variety of reasons. Sometimes I'm going to appointments by myself with the kids. Sometimes my husband is going by himself. More frequently, when we can swing it, we're both together. And in every single appointment that we're both together, he will make an observation or say something that is not something I had thought of, that wasn't something I had observed, that wasn't something I had thought to bring to the attention of the provider. And it is something of value. So by doing telemedicine, you sort of have that opportunity to talk to more than one caregiver more frequently. Schedules can be a little bit more flexible. Even if somebody is working, they could join the visit for a period of time. And this can give a much more well-rounded picture of what's happening with the patient. You have less wait time. You have lower associated costs. I shared with you some of those costs about the road. You have less school and work time missed. You have fewer missed appointments. You know, if I have to drive all the way to Philadelphia or Ohio, or even to downtown Baltimore to Johns Hopkins, and I have important work meetings or something like that, I may have to reschedule an appointment, or I may just have to miss it for some reason. You have greater compliance to care plans. You have easier access to medical records. Sometimes I'm carrying literal binders full of printed information to in-person appointments. Whereas if I am in my living room on my laptop, I can pull up those medical records that I've already scanned and saved to my Google Drive and have easy access to them. Another example, not specific to Mito, one of my kids sees a psychologist for anxiety and depression. They have weekly appointments. We do a family appointment about once a month. Prior to COVID, that meant missing school and work, managing care for our younger kids, for Marshall and Sam, and other considerations. Sometimes it meant missing appointments when one of those considerations had to take priority. With telemedicine, we have zero missed school time, we have zero missed work time, we have zero missed appointments, leading to greater compliance, follow-up with treatment plans, and better outcomes. In fact, with greater compliance, combined with increased involvement from me and my husband, because we have more consistent family appointments, they now have the tools to manage their mental health much more independently, and we're reducing the frequency of appointments. That, to me, is a success story of telemedicine. So, cons of telemedicine, there are a few. So I don't think we want the pendulum to swing so completely in the other direction that all visits are done via telehealth. Some things require in-person visits. There is limited physical exam, obviously, with telemedicine. You're not taking vitals when you have a telemedicine appointment. Sometimes there are deficits with equipment and technology. Not all families are equipped to do a successful telemedicine visit, but there are things that we can do to help support that. So the determination for whether a telemedicine visit should happen or not should be based on the needs of the patient and the needs of the family, not based on the state lines and insurance rules. It should all be based on needs of patient, family, and clinical expertise of the treating physicians. That's Marshall taking a walk, which is the only thing we've been able to do during the pandemic. Some barriers to successful telemedicine appointments and treatment. Honestly, the only barrier that I've encountered in the year plus that we've been doing routine telemedicine appointments is insurance. Marshall and Sam are insured through our state's medical assistance program. They're actually enrolled in an alternative to an MCO because of their condition. This has caused delays in being able to see providers, and more recently has mandated in-person appointments now that states of emergency are ending. And so the insurance really is the only barrier that we've encountered. So when I was in college, I took a class called The World Since 1945. And I suspect in the not too distant future, college students will be taking a class called The World Since 2020. And they will explore how COVID-19 changed the world. And I think we have an opportunity here to really think about how we want COVID to have changed the world. What do we want medicine to look like 50 years from now? I think we have an opportunity here to really take a hard look at where we are and where we want to be and make a plan for how to get there. And there may be obstacles in that plan. There almost certainly will be, but I think it's time to look at what families need, look at what providers need, what we're all advocating for, and move forward in keeping with the technology and where we're going. I just think it would be foolish to not include telemedicine as part of routine care plans, even if we know that there might be obstacles to it. That is it for me, and I thank you very much for your attention.
Well, thank you so much, Stacy, for sharing your family's journey with mitochondrial disease. We know it takes courage each time to tell your story. We also know you're motivated by Marshall and Sam's resolve. You know, for so many of our families, that journey is often a long and arduous one. One year, as Stacy illustrated, that can be a 5,000-mile journey. So we do whatever we can to make that road a little smoother. And improving access to telehealth services does just that. As Stacy shared, this isn't just making things a little bit smoother, it's making a dramatic difference on many fronts. And part of the message we wanted to share with all of you today was understanding the real impact that this has on patient families, but also the real opportunity it has for patient families as well, too. As several pieces of legislation are finding their way to the Hill, we wanted to make sure that we shared our perspective with all of you. And we'd like to take the time now to open up for any questions that you might have for Dr. Parikh or Stacy. You can simply unmute your line if there's a question that you have for the group. Well, if there are no questions today, let me please again thank you all for joining us for today's briefing. We are delighted to have your support in listening in. And I think we have a question from Mr. Bradner.
Yeah, thank you, Brian. And Stacy and Dr. Parikh, thank you for your really excellent presentations. My question was, you indicated there are 40 to 45 people, I think you said worldwide, with the RMND1 mutation. And this may call for a little conjecture, but I was wondering to what extent we think it's underdiagnosed, that people are simply, there may be more people worldwide and in the United States who have this, but it's simply not being picked up by clinicians.
So I can answer how I got that number, and then Dr. Parikh may want to chime in with a clinical perspective on your question about it being underdiagnosed. I actually reached out to our genetic counselor. In 2019, there was a clinical journal article that was written that did an assessment of all of the people who at that point who had been diagnosed with RMND1. So in 2016, it was 35 people. The 40 to 45 number was just sort of extrapolating out. Now, as of this week, there's another one who was diagnosed in the US. I suspect that as technology increases, as the availability of affordable genetic testing increases, as awareness of mitochondrial disease and all of its associated specific diagnoses increases, that we will find more and more people who are diagnosed with these quote unquote rare diseases. So I feel confident in saying that there are other people in the United States and throughout the world who have RMND1 and who just haven't had access to the experts who would be able to refer them to testing or have not been able to afford to get the testing done. I don't know if Dr. Parikh has anything to add to that.
No, that was a great summary. I think one of the challenges with these publications is the networks that are reporting them are often siloed. So, you know, if there is a Italian network or a German network or a European network, they rarely will reach out past those countries that they usually work with. And so we know that these reports, while they're very valuable from our side about learning about what these individuals look like as far as their symptoms go, it usually very much underestimates how many people are out there with it. So I think I always tell families that, yes, there have only been 30 or 40 or 50 patients reported, but that those are just the ones the researchers sought out. And that there are likely many even diagnosed patients. What has been more useful, I think, in helping estimate numbers are the family support groups that have formed around these diseases, sometimes using forums like Facebook, because families will find these supports themselves, and then you end up getting a little bit of a bigger picture. The number doesn't grow dramatically, but we might go from 40 to 100. So it's a little less rare, relatively speaking, than what initially gets presented. I think the second thing is the access and ease of genetic testing in the United States is fortunately better than what it is in other parts of the world, where there is a bit of a screening process in place, and you don't get genetic testing and the kind of genetic testing that we get here done as quickly or easily. And because of that, I suspect the diagnostic rate is also a bit higher in the United States. That being said, most of the major countries in Europe and in the UK all have access to this technology, and eventually many of these families do get tested. It just, their journey, their diagnostic odyssey is often a bit longer than what some of our families see nowadays, especially in the last 5 years.
Thank you. Looks like we have a question from Suzanne Joy.
Hi, yeah, thank you so much. And thank you both for being here and lending your insights. I know sort of a consistent theme that you guys mentioned was the kind of interrelatedness to other particularly rare diseases, but just, how it's not just this one singular set, and how a lot you guys experience a lot of the same kind of issues and barriers. So with that, I'm just curious, as these conversations do continue here in DC, have you guys been talking to other groups or other specialties or running into other families that, with different diseases that are kind of landing at the same conclusion that we really need to continue this telehealth, and you're seeing this kind of being more consistently across different groups and diseases?
Dr. Parikh, it might be best to have you tackle that one first.
Sure. Yeah. While my clinical research focus is mitochondrial disease, my day-to-day practice is individuals who have genetic diseases, pediatric or adult, that affect the nervous system. And so a lot of what I see involves rare disease. And my partners who see individuals with neurologic conditions, unfortunately affecting mobility, are also dealing with some of the same things, regardless of what is causing these issues. So our partners over dealing with multiple sclerosis versus ALS versus dementia versus, from the pediatric side, cerebral palsy, telehealth has allowed for access to care that we never had before. We can do check-ins on families. Before, we might limit visits to once a year. We can now do a 3-month or 6-month check-in, which is wonderful. Some of the families that need that extra support are able to receive it. For the families that want to come face-to-face, they can still come, but we might be able to push those visits out to every 2 years if they're doing well, and dive in and do a 9 to 12-month check-in virtually. So I would say absolutely. And I know at Cleveland Clinic, the numbers that are being touted, the Neurologic Institute is one of the highest users of telehealth services for all the reasons we outlined. Not to say that other institutions in our center are not using telehealth, but it turns out the neurologic centers are the most highest utilizers.
Any other questions? I'm gonna allow for an extra long pause this time as I jumped the gun the first time there. All right. Well, once again, we thank you all for joining us today. We will be in touch with your offices and continue these conversations. We're always grateful to be able to come visit you when the time is right for that as well, too. And if you have any additional questions, you can also be in touch with our Director of Advocacy, Cliff Gorski. He can be found at cliff@umdf.org. Thanks again to Stacy for sharing your story, Dr. Parikh highlighting the challenges and opportunities that we have in telehealth. Thank you all for joining us and have a great day.